Okay, to assess the thorax, ask the patient to breathe normally. Can you please sit properly, ma'am? And can you please breathe normally? So, while observing the respiration should be
So now I will move around to my patient's back. And normally, the lateral diameter is up to twice the anterior-posterior diameter for a ratio of about 2.1. So now, I will use my finger pads to palpate the spinous processes, and they should be evenly spaced and non-tender. Now I will assess respiratory expansion. Now I will place my thumbs at the level of T10, and I will spread my fingers, allowing for small folds of skin between my thumbs, and I will ask the patient to take deep, slow breath. As she does, I will watch my thumbs move with respiration, and their movement should be symmetrical. Now, I will assess for tactile firmitos or voice sounds palpated on the chest wall surface. Using the ball of my hand, I will feel for vibration as the patient repeats the phrase 99. I will move from trapezius inside the scapula down to the lower and lateral thorax. Each location, you should feel equal vibration. We will perform a mediate percussion using a systematic pattern so you can compare the two sides. Resonance should be equal over the lungs, and you should hear dullness over the diaphragm. Hyperresonance means you found an area of increased air in the lungs or pleural space. Example, pneumothorax or acute asthma. Abnormal dullness means there is decreased air in the lungs, example, atelectasis or a build-up of pleural fluid. Now, assess for diaphragmatic excursion. Ask the patient to exhale and exhale, then hold his breath. As he holds his breath, percuss from the scapula down to where the sound changes. From resonance to dullness, mark the spot with a pen. Patient to inhale deeply and hold his breath as you percuss further down to the area of dullness. Mark this spot too. Repeat process to the other side and measure the distance between the set of marks on each side.
Next,
Normally,
assess the
hit
kidneys
this
using
distance,
blunt
which
or fist percussion
represents
over the
diaphragmatic
costovertebral angle.
excursions, measures 3
Percussion in
to
this
5
area should
cm
not cause
and is
tenderness.
equal on both sides.
Finally, auscultate breath sounds with the diaphragm of your
Auscultate breath
stethoscope.
sounds. Use
To
the
do this,
diaphragm of the
instruct the patient to
stethoscope.
breathe
Instruct
deeply
the
through his mouth.
patient to breathe
Starting at the
deeply
lung
through his
apices,
mouth.
auscultate
Be
the
sure
lungs.
to listen for
Move
at least
systematically
one
from side
complete
to side,
respiration
down the
at
patient's
each
back
location.
and laterally toward
Normal
the
breath
axillae.
sounds vary
Be sure
with the
to listen for
area
at
you are
least one
assessing.
complete
Should
respiration
be
at each
able to hear
location. Normal
bronchovascular
breath
sounds
sounds vary
between
with
the
the area you are
scapulae.
assessing.
These sounds are moderate
You
in
should hear
pitch and
bronchovesicular
amplitude,
sounds
with
between the
an
scapulae.
inspiratory
These
pace
sounds are
equal to
moderate
the
in pitch and
expiratory
amplitude,
pace.
with an
Should
inspiratory
hear
phase equal to the
vesicular
expiratory
sounds at the
phase.
apexes down to the bases, and laterally, these
You
sounds
should
are
hear
low pitch
vesicular
and
sounds at
soft,
the apices,
with a longer
down to the bases
inspiratory
and
pace than
laterally.
expiratory
These sounds
pace.
are
Listen
low-pitched
for
and soft,
abnormal
with
sounds
a
such
longer
as
inspiratory
crackles
than
and
expiratory
wheezing,
phase.
for coughing, and for abnormal respiratory effort. To hear crackles or wheezing, ask the
Listen
patient
for
to
abnormal
cough, then
sounds,
listen
such as
again to
crackles and
determine if
wheezes,
the
and for
abnormal
coughing
sound
and
had
abnormal
cleared.
respiratory effort.
Crackles
If you hear crackles or
result
wheezes,
from
ask the
collapse
patient
or
to cough,
fluid-filled
then listen again to
alveoli
determine
popping
if the
open.
abnormal
They
sounds
have a
have
fine
cleared.
crackling or sometimes a
Crackles, which can
bubbling
be heard on
sound.
inspiration and
Wheezing,
sometimes on
which can be
expiration,
heard
result
during
from collapsed
both
or fluid-filled
inspiration and
alveoli popping
expiration, are
open.
high or low
They have a
pitch.
fine
They
crackling or
indicate
sometimes a
airway
bubbling sound.
obstruction.
Wheezes, which can be heard on both inspiration and expiration, are high or
So
low
if
pitched.
we
They
suspect an
indicate airway
abnormality,
obstruction.
have the
If you
patient to
suspect an
say
abnormality, have
99
the patient
as
say
we
99 as
auscultate
you
these
auscultate these
areas.
areas.
And normally
99.
the words sound muffled and
99.
indistinct. So now assess the patient's
Normally, the words
anterior
sound muffled and
thorax.
indistinct.
Begin with the
To
bones
assess the
and
patient's
muscle.
anterior
So
thorax,
normally they
begin
appear
with the bones and
symmetrical,
muscles.
and you should
Normally,
not
they
see
appear
accessory
symmetrical,
muscle use,
and you should not see
retraction,
accessory
or
muscle use,
bulges.
retractions,
Should not
or
have
bulges.
signs of
The
respiratory
patient should
difficulty
not
such
have
as
signs of
cyanosis or
respiratory
nasal
difficulty,
flaring.
such as
Palpate
cyanosis
the
or
thorax
nostril
with your
flaring.
finger pads, moving from the
Next,
lungs
palpate the
apexes to the
thorax with your
bases.
finger
You should
pads,
find no
moving from the
nodules
lung
or
apices to the
tenderness.
bases. You should find no nodules or
To
tenderness.
assess respiratory expansion,
To
place your
assess
hands on the
respiratory
patient's
expansion,
chest along the
place your
costal
hands on the
margins,
patient's
with your
chest along
thumbs
the
pointing
costal
towards
margins,
the
with your
xiphoid
thumbs pointing
process.
toward the
Have
xiphoid
the
process.
patient take a few deep
Have the
breaths.
patient take a
As
few
he
deep
does
breaths.
this, watch
As
your
he does
thumbs.
this, watch your
Should
thumbs.
move
They should move
simultaneously and
simultaneously and
symmetrically.
symmetrically.
Assess for tactile firmitos.
Now assess for
Patient repeat the
tactile
praise
firmitus as the
99
patient
and move
repeats the
from the
phrase
lung
99.
apexes down to the point below
Move
the
from the lung
nipples
apices
and
down to a
comparing
point below
sides.
the nipples.
Vibration
Comparing
should feel
sides.
equal but stronger in
Vibrations
the
should
upper
feel
chest
equal
than
but
the
stronger
lower
in
chest.
the upper chest than
Perform
the lower
percussion
chest.
over the lungs. Use
Next,
a
perform
systematic
percussion over the
approach.
lungs.
Start just
Using
above
a
the
systematic
clavicle
approach.
and percuss in
Start
the
just above the
intercostal
clavicle
spaces
and
down the
percuss in the
chest from
intercostal
side to
spaces
side,
down the
and
chest
percussion
from side
should
to side.
produce low
Percussion
resonance
should
sound.
produce low resonant sounds.
And auscultate over the
Then
patient's lung
auscultate
with
over
the
the patient's
diaphragm of
lungs
the
with the
stethoscope
diaphragm
in
of
the
the
same pattern
stethoscope
used
in
in
the same pattern
percussion.
you used
Each
for percussion.
location, listen
At
for
each
one
location,
complete
listen for one
respiration.
complete
Normal
respiration.
breath sound vary with
Normal
the
breath
area
sounds
you are
vary with the area
assessing,
you are
and you
assessing.
should hear
You should hear
tracheal sound
tracheal
over the
sounds over the
trachea,
trachea.
and these are
These are
high-pitched,
high-pitched,
loud, and tubular.
tubular.
You should hear bronchovesicular sound laterally and over the bronchi at
You
the
should hear
angle of
bronchovesicular
Lewis.
sounds laterally and over
Expect
the
to hear
bronchi at the
vesicular
angle of
sounds
Louis.
over most of the
Expect to hear
anterior
vesicular
thorax.
sounds over
If you
most of the
suspect an
anterior thorax and the
abnormality,
periphery.
have the
If you
patient
suspect
say
an
99
abnormality,
several
have the
times
patient say
as you
99 several
auscultate the
times
areas
as you auscultate
involved.
the areas involved.
Normally, the words
Normally,
sound
the
are
words sound muffled
and
and
indistinct.
indistinct.
So good afternoon, everyone. My name is Julian Yudik-Dikin, your assistant nurse from today, and I am going to continue the procedure, which is the neck assessment and the neck tutu assessment. So before we will start the procedure, I will sanitize my hand first. To avoid microorganisms. And I will remove my jewelries. And so to lower down his gown to see the neck. So I will first observe the neck of the patient. The patient neck should hold the erect and midline, and it should symmetrical muscle and no swelling and no masses. And then if you see swallowing in the jaw angle, you should palpate this area to check the parotid gland. So the next is assess the neck of the active range of motion. So, sir, can you please touch your chest? Sir, can you please move your head to the right side and then the left side? Tip your head to right side and to the left side. Okay, sir, can you turn your head backward? And then, all of this move should smooth and painless. So next is assess the spinal accessory nerve. Okay, sir, can you raise your shoulder? Can you raise again your shoulder, sir? And then the shoulder muscle should be symmetrical. So, okay, sir, can you move your head to the left side? And then same. Okay. Note the construction of the opposite of the sternomastoid muscle and force the movement against your hand, and move should equally strong. So the next assessment is the lymph nodes in the neck. So use fingertips in the both hand and laterally palpate the node using circular motion. The first is we will check the free auricular. Then the posterior auricular, and then the occipital, and the next is submental, and submandibular, and then the tonsillar here, the superficial cervical, and the next is deep cervical, and posterior cervical, and then the cervicular. Note the size, shape, consistency, mobility, tenderness of the node. And normally the lymph nodes small, movable, soft, and non-tender. And if you detect swallowingness, search for possible cause. So next is inspect the jugular vein using a pen light. And sir, can you move your head in 30 degrees? So I will observe the neck using my pen light. So we're done observing the jugular vein using pen light, and now we will palpate the jugular vein pulsation. They angulate softly and may decrease with inspiration, and note a prominent pulsation. And setting up, identify the trachea by locating external notch, and we will be using our 2 fingertips to palpate the trachea. Trachea should be midline and symmetrical. Use finger in the left and hand to push thyroid in right. Sir, can you swallow your saliva? Okay, sir, can you hold the water?
calmness and hope in my heart every day. Remembering and holding your hand, making me feel like everything I can wish.
Can you drink your water, sir? Okay. Note the size, shape, consistency of the thyroid, and if the thyroid is enlarged, auscultate the roots by bell of the stethoscope. Roots is following sound by turbulent blood flow, and observe the carotid artery and gently palpate the carotid artery using index and middle finger. Remember to palpate the carotid artery one at a time, otherwise you could block blood flow to the brain. Don't press too hard the carotid artery or sinus area because it can cause vagostimulation or it can slow the patient's heart rate. Sir, can you please take a deep breath and then hold? Sir, can you please take a deep breath and then hold? And we should not hear both.